Xin mời chúng ta tiếp tục chương trình. Thì đầu tiên thì xin giới thiệu giáo sư Robert Gitt. Giáo sư Robert Gitt là một trong những giáo sư về gan và có quan hệ rất thân thiết với các bệnh nhân gan ở Việt Nam, và đặc biệt là đối với các bác sĩ chuyên ngành gan. Và chúng tôi cũng rất là nhiều lần đã được làm việc cùng với giáo sư Robert Gitt. Thì phần trình bày của giáo sư Robert Gitt là phương pháp điều trị viêm gan B, có phương pháp điều trị nào mới triển khai. Xin mời giáo sư Robert Gitt.
Hello, my name is Dr. Robert Gitt. I'll be discussing emerging therapies for hepatitis B and on hepatitis delta. I want to thank the Vietnam Association for having me at this very important meeting. Hepatitis B is an extremely important disease for Vietnam and the world in terms of the number of people infected and the number of people affected with those risks of cirrhosis, cancer, death, and transplant, as well as being infectious, as well as the major issue of stigma. My disclosures are available on my website, and there's quite a number of resources that are available here as well. I would like also to thank Capsid for having me for this wonderful presentation, and I look forward to seeing you in person next year. Xin chào quý vị. I will now start my presentation to talk about hepatitis B testing part 1. Each patient needs to have this triple panel of surface antigen, core antibody, and surface antibody baseline. If surface antigen is positive, of course, you're going to be checking patients for quantitative DNA E antigen, but I would like to emphasize here to check for delta antibody as well. Delta infection in Vietnam ranges from 1 to 10% and is the most fatal, most serious form of chronic liver disease. There are new treatments emerging for delta as well. Core antibody equals exposure or cccDNA persistence. Do not vaccine boost patients who are core positive. There's a reactivation risk, and consider evaluation for occult hepatitis B. Anti-HBs only means immunity. Core antibody is negative. There is no natural immunity to hepatitis B, but there is something called immune control. Hepatitis B is not curable, but it is treatable. There is functional cure for hepatitis B, and that is our next goal with any new therapy. But remember, cccDNA, an integrated virus, persists in all patients long-term until we have newer, more advanced therapies. ALT, AST, alk-Phos, and GDT are liver enzymes. They are not liver function tests. The current guidelines are a barrier to treatment, too complex and too many gray zones. We are moving forward to treating all patients who are HBV DNA positive. Hepatitis B Foundation recommends testing all adults for hepatitis B with a triple panel. I believe this is standard of care in Vietnam, but in the US, this has come under controversy and it's been risk-based testing, which has failed and does not lead to hepatitis B elimination. Treatment for hepatitis B includes counseling about infectivity, laboratory testing, imaging, education, testing the family, and lifestyle management. We need to destigmatize hepatitis B. I'm now going to go into new treatments for hepatitis B in development. These slides are very complicated. They will be shareable through your association. And I look forward to seeing questions by email or potentially through a panel. So we have entry inhibitors listed on the left side that block uptake. We have release inhibitors that block surface antigen and viral particles release. The standard of care is nucleoside or nucleotide analogs, which is TDF, TAF, or entecavir. TAF is my first line therapy, but sometimes based on cost, TDF or entecavir need to be considered. We will eventually target cccDNA. There are ways of targeting X right now through small interfering RNA. CAMs, CPAMs, capsid inhibitors are also available. We may be modulating the immune system by changing CD8 T cells and B cells. Antibody production or direct cells and vaccine therapies are all in development. We do eventually want to go beyond functional cure to sterilizing cure, which means removing all cccDNA, or complete cure, which removes integrated virus as well as cccDNA and infectious particles. I will be moving quickly through the next series of slides, highlighting the research, the mechanism, and a few results. What about small interfering RNAs? These are molecules that bind to viral RNA through a RISC complex and resulting cleavage of these molecular signals. Arbutus recently had a change in HBV markers after a single dose of GalNAc siRNA. The message here is GalNAc is used to deliver siRNA and other molecules to the liver through this galactose surface attachment. You can see on the left, there's a reduction in surface antigen levels and a reduction in HBV DNA levels. It's a rather complex design, but this is what happens when you go through healthy patients, single dose, and then multiple dose to try to discover what's the safest and most effective to balance risk and benefit. A single dose here with more detail, you can see on this slide that there's extreme heterogeneity in terms of viral response depending on the patient. An important message on this slide is a new protein that we look at. It's actually 3 proteins called correlated antigen that also showed very slight changes. But correlated antigen, like HBV RNA, which is the middle graph, relate to cccDNA activity, transcriptional activity. If you suppress RNA, the correlated antigen, it then implies an effect on cccDNA activity or maybe levels. Repeat dosing of this also resulted in even more profound and more durable responses to surface antigen, which you can see on the left, middle, and then right, depending on the dose that was here and dosing frequency, monthly, every 2 months, with doses ranging from 60 to 90 milligrams. Another fact that we need to look at here is these changes in correlated antigen on the left. There are 3 proteins that make up this correlated antigen, including core, E, and a modified P protein. Patients start at different levels and have different levels of response. One of the challenges with this assay is that it's not FDA or regulatory approved anywhere in the world at this time, and it has relatively low sensitivity. So some patients will be close to being negative at baseline. It's unclear specifically about that response. You can look also in the different cohorts in the middle graph here that show the surface antigen decline of about 2 logs. What's interesting about the different siRNA compounds that are available through companies like Arrowhead, now under Janssen, that this 2 to 3 log reduction is pretty typical and then a plateau effect. So clearly effective, but it's going to be part of combination therapy. S antigen by RNA interference is accompanied by changes in T cell activation markers. One of the 4 pillars of hepatitis B treatment will be immune modification, in my prediction. And I think in the next wave of drug or medication activity against hepatitis B, we will have nukes, we'll have CPAMs or some type of release inhibitor. We're going to have immune modulation, and we're going to have interfering RNA, or what are called ASOs, which I'll talk about shortly. Here we're seeing some level of immune activation as we suppress virus. This is a little bit more specific about looking at T cell activity, including interferon gamma and T cell proliferation, different profiles in different patients. The message here is that we're probably going to end up having to personalize the treatment of hepatitis B. What genotype? Do they have core or pre-core mutations? The level of integration, the activity of cccDNA, ethnicity, gender, how long the disease has been present. Being able to immune profile patients before we start treatment may allow us to customize our different treatment combinations for patients. This restoration of hepatitis B specific immune response was quite provocative, and I believe will be part of many of the new studies in hepatitis B drug development. And it's not just during treatment, but what's happening with patients at baseline? What's their baseline profile? Let's now talk about Vir 2218 is also a small interfering RNA. This is focused on the X gene. This is silencing both integrated DNA and cccDNA transcripts. So this is quite innovative. Integrated DNA can make surface antigen and actually make us think that we haven't had a functional cure in patients. So if we silence integrated DNA, we may further achieve higher levels of S antigen loss. There's a new stabilization chemistry to make sure there's less off-target effects. Good news to date, in my opinion, both with the iRNAs and with the ASOs, we haven't seen any specific off-target effect. In combination with PEG interferon as an immune activation, may bring forward better responses. On the left side, lower graph, you're seeing minimal ALT changes, except in one patient went up to 200. No changes in bilirubin were seen in those patients, fortunately. We have this reduction in S antigen. As I mentioned before, this is typical for siRNA to reach about a 2 log reduction, reinforcing my message that the secret in the future will be combination therapy, I believe. No single therapy will be sufficient. Nukes, rarely getting S antigen loss or rarely having an S antigen effect. Here we have an S antigen effect, but not S antigen clearance. Combining with something like a CPAM or a STOP, or combining with immune modulation will be very important. So this is well tolerated, reduced S antigen, as I mentioned. The PEG resulted in a faster, greater decline in S antigen than the iRNA alone. More research to follow. ASOs, antisense oligonucleotides, bind instead of RNA to DNA. As you know, Hepatitis B virus goes through reverse transcription step to RNA and then reverse again to DNA. We're seeing on the left with this ASO, a randomized phase 2A from GSK, an S antigen decline in both E positive and E negative patients that was dose related. There appeared to be at least modest benefit in potentially in nuke-treated patients. You see a graph about the S antigen reduction, and you're seeing in that reduction about a 3 log. But interestingly, on the right, an ALT response, an ALT flare. Now, flares often frighten providers, researchers, and patients, but we think flares may be beneficial in a variety of different patients as immune reactivation, immune reconstitution takes place. This S antigen reduction, ALT increase, also showed a change in a variety of acute phase proteins, extracellular matrix, and markers of innate and adaptive immune activation. This is incredibly important research, identifying that in responders, which you see on the right side in the third column over, a more profound immune profile that's taking place. So ALT changes in this case was an immune-regulated event resulting in or part of viral reduction, not due to drug-induced liver toxicity or viral rebound. We're now going to change to CAMs, CPAMs, Capsid assembly modifiers. This is a very, very seminal study published at EASL last year. These are compounds that prevent packaging. As you know, hepatitis B goes into this RNA, then goes to a DNA inside a capsid molecule, and that's surrounded and then eventually surrounded by surface antigen with a lipid envelope. This did show with this wonderful drug, which we're going to call VBR for short, is resulting in virologic outcomes with profound virologic reduction. But the challenge is after cessation, every patient relapsed. No SVR, no S antigen loss. There was a decline in E antigen, modest effect on surface antigen, substantial effect on HBV DNA, but everybody relapsed. We have now moving even to 4th generation CPAMs. In spite of this relapse data that you see here, am committed to this class of medications as being one of the pillars or foundations of our future therapy. A little bit more information here on relapse, HBV DNA levels, higher viral levels on the left, univariate logistic regression predicted off-treatment HBV DNA viral load. HBV e antigen negative did better. Correlated antigen that was lower did better. E antigen positive patients who have a younger age did better. This response and safety profile also did not show any sustained HBV DNA suppression. On treatment, CAM did have an additive effect of viral suppression and a marked reduction in excess of HBV RNA, which implies there is an effect on cccDNA, potentially through decreasing cccDNA replenishment. We're going to change now to NAPs, nucleic acid polymers. These live in both a charged and uncharged state and form this amphipathic alpha helix that then interacts with a variety of different viruses that are listed here, including coronavirus, interestingly. The mechanism of action isn't fully understood, but it appears to target this DNA JB12 to inhibit HBV spherical viral particle formation, these spherical viral particles from forming, which are part of making viral particles. This interaction appears to block packaging of HBV virus in the cell and then subsequently release. This antiviral effect of NAPs can decrease the level of circulating surface antigen and viral particles up to 99.99%. Inside the cell, there becomes a constitutive intracellular degradation of surface antigen via proteasomes, ultimately decreasing full viral particles and S antigen release. Fortunately, there is no evidence of liver failure, but there are liver flares that take place that may be immune-related, and current data does not support that these are intracellular cytotoxic compounds. They also are interacting with this HPS 40 chaperone of DNA JB. They've been optimizing this because this is an intravenous infusion. What needs to happen is modification of this so they can give this subcutaneously and look beneficial. This is what happens. NAPs with TDF, with PEG interferon, results in a profound drop in hepatitis B surface antigen, up to 8 logs, and a substantial number of patients who have anti-HBs accompanied by surface antigen seroconversion. The goal of this, though, is to use it in combination and change from an intravenous infusion to a sub-Q application. ALT changes were seen in patients without changes in liver function, no changes in bilirubin, and these were asymptomatic. And these flares correlated with S antigen decrease, and in many patients, S antigen loss. Let's now talk about stops, which are similar to NAPs. We'll call this second or third generation transport inhibiting oligonucleotide polymers. In animal studies, there are changes with surface antigen, polymerase, and decreasing extracellular surface antigen. This is very important, and changes in core protein and also HBV RNA. This does not co-localize with surface antigen. It also does not activate nucleic acid sensing immune receptors. This may have a similar effect to the NAPs, but less changes on ALT. As you can see, there are modest effects on core and HBV RNA and major effects on surface antigen. This may also be a partner and become a pillar in our management, and I'm awaiting phase 3 data. A little bit more on mechanisms, stops and knockdowns of RPLP1 and 2 and GRP78. They increase this ubiquitination and proteasome degradation, resulting in better, I believe, surface antigen clearance. This is the allogose compound stop showing minimal challenges. This is injectable, and hopefully will be dosed at weekly 2-week or 4-week intervals ultimately. We can now change the monoclonal antibodies. These have been tried in the past 10 to 20 years ago without significant benefit, and in some cases resulted in HBV mutations and fibrosing cholestatic hepatitis with these hepatitis B variants. Much science has taken place, and Vir, a company we talked about a short time ago with an iRNA, has this phase 1 data with neutralizing monoclonal antibodies that appear to inhibit viral entry, are involved with cross-presentation to and stimulation of T cells, and clearance of S antigen by binding and delivery to dendritic cells. These immune complexes bind FCRs and dendritic cells and involved with a downstream generation of effector T cells. Very, very interesting science that's behind us. We've got information here about demographics and baseline characteristics of Vir 3434 or placebo patients were relatively typical for our patients, although they had a mixture of Asian, white, and Black patients here. Healthy BMI, surface antigen level, I want to highlight here, though, is relatively low, less than 1,000 in cohort 2B, about 200 in cohort 1B. Safety and tolerability look excellent. Here we're seeing changes with this monoclonal antibody and surface antigen with minimal changes in ALT. This rule of 1 to 2 log reduction across different drugs and drug development is quite interesting. We highlighted that with the iRNA and ASO. It's interesting here too, we're in the 1.5 log range with this monoclonal antibody. But hopefully with combination therapy, we can stack these surface antigen modifications and suppressions. Therapeutic vaccines, I think, also may be part of what we do next. This is a compound therapeutic vaccine called BRII-179, formerly known as VBI-2601, looked at in the phase 1b/2a study, looking to see if we have data that could suggest that this could add to our functional cure. We have virally suppressed patients, non-cirrhotic, in part 1 and part 2 that are here, different dosing and dosing intervals. You can see in cohort E, we have interferon alpha as part of that combination. Both dose levels with and without interferon administered to IM injection were safe and well tolerated without significant siRNA. There is an anti-HBs antibody response in over 30% of patients. Restored or boosted pre-S1 and pre-S2 specific interferon gamma producing T cells. No or minimal reduction in S antigen was observed, though, and we'll wait further data, most likely in combination therapy, to see if this will be of assistance, especially within their company. They may be able to combine this with an siRNA. I want to wrap things up with integration. Both cccDNA and integrants are involved in making surface antigen, although cccDNA, of course, is the template for all of the different viral molecules. Can we reduce intrahepatic cccDNA and virologic markers that indicate a decrease in integration through deep whole genome sequencing? We believe if we decrease integration, not only will we produce less S antigen, but more importantly, be less oncogenic. In this study, intrahepatic cccDNA levels were significantly decreased in patients treated with nucleoside or nucleotide analogs. There was a functional cure in 4 patients with S antigen loss. The patients with functional cure had a low level of virologic relapse, and in the functional cure patients, HBV integration was much lower than treatment-naive chronic hepatitis B patients and those who did not undergo a functional cure. So these are the pillars that we talked about as we began and also integrated into our talk. We have nukes and super nukes. I'd like to highlight Antios 2137, which I think it's 2173. That's a clevidine analog. This clevidine compound is very, very important in terms of long-term viral suppression. And with this prodrug, it minimizes any safety concerns. iRNA, ASO, we talked about here. We have Arbutus, GSK, Vir, and Janssen in this space, plus others. Release inhibitors, we talked about Replicor and Aligos, but there'll be other companies in this space, I believe. We now have 4th generation CPAMs. Up above, you'll see pillar 5, pillar 6, pillar 7, and pillar 8 with other potential targets of hepatitis B, new therapies. In conclusion, we're looking for a functional cure. The next wave of medications, I believe 1 year of treatment or less, and a functional cure rate of 40 to 60% will be needed to engage providers, patients, and also to provide a good return on investment for all the people investing money and time in developing these new drugs. The 1 year seems to be a magic number for patient engagement, compliance, adherence, interest. This 3 to 4 drug combination, I think, will be key, including immune modulation. Immune therapy, I think, in the next wave will be key for a stable, functional cure. I would like to thank Vassal for having me here, Capsid for your kind invitation. I look forward to seeing you in 2022 in person to further go over what's happening in the hepatitis B world. Thank you.
Vâng, xin cảm ơn phần trình bày của giáo sư Robert Kitt cho chúng ta thấy những các cái hướng để điều trị viêm gan virus B trong cái thời gian tới. Đây là một cái bài trình bày nó rất là hay và có ý nghĩa. Thì trong cái chương trình có ai có câu hỏi gì không em? Vâng, trong chưa có câu hỏi nào thì trong hội trường của chúng ta hoặc là những người đi theo dõi ấy, thì ai có câu hỏi nào thì chúng ta sẽ hỏi giáo sư. Vâng, mời giáo sư Bình ạ.
Alo, giống như là một cái tổng quan lại cái tình hình cập nhật về vấn đề điều trị viêm gan B. Một cái câu chốt mà tôi nghe thấy trong báo cáo là vấn đề monotherapy hiện nay đang là một thách thức rất lớn. Và cũng không có monotherapy nào có thể đạt được một hiệu quả mà tốt nhất trong điều trị viêm gan B. Nên cái đầu ra của cái báo cáo này là trong tương lai ấy, sự phối hợp của điều trị, đặc biệt là trong cái kết luận cuối cùng giáo sư nhắc tới vấn đề phối hợp với điều trị về miễn dịch học thì nó sẽ mang một cái tương lai sáng sủa hơn. Cái câu hỏi của tôi chỉ có một ý là vậy thì trong một dãy các cái khả năng như thế thì có thể giáo sư liệt kê cho độ khoảng 2-3 cái khả năng tiệm cận gần nhất trong một cái horizon rộng rãi như thế, thì có cái nào nó nằm trong cái tầm tay nó gần nhất để chúng ta có thể có một cái định hướng. Theo tôi thì chắc câu hỏi này thì giáo sư không trực tiếp ở đây thì có thể đưa vào trong cái phần chat cũng được. Vâng, xin cảm ơn.
Vâng, cảm ơn câu hỏi.
Hay là chủ tịch đoàn biết, chủ tịch đoàn trả lời luôn.
Vâng, của giáo sư Bình. Thì những cái vấn đề này nó rất là khó và giáo sư Bình ạ. Đấy thì theo giáo sư Robert Kitt sẽ trả lời câu hỏi bằng email sau và thư ký sẽ chuẩn bị những cái câu hỏi và để giáo sư Robert Kitt trả lời. Yes, xin cảm ơn. Ai có kiến gì được không? Thư ký có câu hỏi ngay.